Hello, everyone. I am Rahul Gosain,
And I'm Fred Hutch.
and we are Oncology Brothers. This time of the year is always exciting as a community oncologist, as we have a lot of data from San Antonio Breast Cancer Symposium, and of course, also from ASH Annual Conference. With so much happening around us, our focus still remains on key practice-changing studies. With that in mind, we're joined by Dr. Mazyar Shadman from Fred Hutch Cancer Center to go over 4 important studies in leukemia and lymphoma space from ASH 2023. Mazyar, thank you so much for joining us.
Great to be here.
Mazyar, welcome. Mazyar, we'll start off with 2 studies looking at CLL and then switch our focus to Hodgkin's lymphoma, and then lastly, closing with diffuse large B-cell lymphoma. Let us dive right into the space of Zanubrutinib, which was FDA approved for CLL or SLL in January 2023, based off these 2 studies. First is the ALPINE, and the next we'll be talking about is SEQUOIA. So ALPINE study, starting with refractory relapsed CLL patient population, can you please walk us through the study design and its findings?
Yeah, very, very important study. ALPINE, as you mentioned, was the endpoint that showed the progression-free survival benefit of Zanubrutinib over Ibrutinib was presented and published last year, and that was with a follow-up of 29 months. And many of CLL experts had the question of, okay, what will happen with the longer follow-up? And naturally, people would put this in contrast with the ELEVATE-RR study, which was another study comparing acalabrutinib with Ibrutinib. And on that study, around the month 33, the curves kind of flipped and crossed. So the question was the benefit, or will the benefit that we're observing in favor of Zanubrutinib persist when you have a longer follow-up? And this year, we had a longer follow-up of the study. And we saw that, yes, with the 36-month landmark of 65.8% versus 54.3%, Zanubrutinib in entire cohort is superior to Ibrutinib from the progression-free survival. We also saw that the same benefit we'll still see in the 17p and p53 mutated population, which was a predefined endpoint. So Zanubrutinib continues to show that clinical benefit, which is important. Another set of analysis that we did in this long follow-up was that we did a number of sensitivity analysis, kind of looking only at patients who progressed while on therapy, looking at it, and also by censoring patients who died because of COVID-19, and also censoring patients who started new treatment before progression. And these are all based on the questions that we were being asked from our colleagues and from the community physicians. So I think with the follow-up that we saw and we presented, which is, by the way, the final efficacy follow-up from ALPINE, we're now seeing the continued efficacy and also improved safety profile of Zanubrutinib compared to Ibrutinib. And this is the only study that shows efficacy benefit of any BTK inhibitor over Ibrutinib in CLL.
Mazyar, this is very encouraging. And Rohit, I recall we actually covered ALPINE with Aaron Goodman last year for ASH 2022. And as both of you have stated, these studies led for the approval of Zanubrutinib in this particular space. But again, the matter of fact is most of our patients will see these BTK inhibitors in first line, which brings us to the SEQUOIA study. Mazyar, your thoughts on the study design and particularly the findings here?
Yeah, SEQUOIA is the study that led to the approval of Zanubrutinib in the first line. Very briefly, the patients who were considered kind of FCR ineligible by age or comorbidity were randomized to receive either standard of care bendamustine rituximab at the time or monotherapy with Zanubrutinib. This study was presented and published, and we presented the longer follow-up at the Lugano meeting and EHA meeting in 2023, and showed the continued advantage of Zanubrutinib over chemoimmunotherapy, and in both mutated and unmutated IGHV population. There is a cohort 2 from this study that only focused on patients with del17p, and of course, these patients received Zanubrutinib monotherapy, and the interesting finding was that the progression-free survival was pretty similar in patients with del17p, similar to the pre-53 normal population. And one of the interesting findings, and again, I'll get to the ASH presentation, but it's important, the CR rates with Zanubrutinib in this first line studies around 17%, which is really, with BTK inhibitors, we don't expect CR rates. I mean, the quality of response gets better over time, but they're mainly partial responses. So with that background, I mean, at ASH, we looked at some of the subgroup molecular subtypes that you see here listed, and I'm not going to read, but just focusing on the Zanubrutinib cohort, the idea was to see if either one of these molecular kind of changes would predict a shorter response to Zanubrutinib, and the conclusion is that they did not. So, in principle, Zanubrutinib works for CLL. Doesn't matter if you have p53 abnormal gene mutated or deleted, and also looking at the list of changes you see. I mean, I would just mention that when you look at the mutated p53 gene, the hazard ratio there and the p-value seems statistically significant. But I mean, if you look at the actual value of PFS at 4-year follow-up, it's around 79% versus 80, like low 80% with non-17p. So a very safe option for patients with CLL, regardless of their molecular profile.
Thanks for going over that, Mazyar. And these are very promising results, especially when you talk about the side effect profile, and now you add on the benefit of it working in 17p deletion the same way as in other subgroups. That's very impressive. Mazyar, in comparison to Ibrutinib, any important side effect profile or clinical pearls that you would recommend, especially when we will be utilizing quite a bit of this in community?
Yeah, so great question. Zanubrutinib doesn't have a side effect that's new or something that we have not seen with Ibrutinib. With acalabrutinib, headache is of course something that some patients experience. We don't have a kind of a unique side effect. In ALPINE, which we just discussed before this study, we saw that the hypertension rate is not lower compared to Ibrutinib. So it's not higher, but every other side effect occurred at a lower incidence except for hypertension. So I would say in patients with hypertension and difficult to control hypertension, those patients need to be monitored if they're on Zanubrutinib. And this is an information that we need to know. Neutropenia was something that in other studies we saw a higher rate with Zanubrutinib compared to Ibrutinib. We're not seeing that in ALPINE. In fact, the rate of neutropenia is not different and numerically even higher with Ibrutinib. So in principle, no new safety signal. Almost everything is less common, and hypertension doesn't seem to be different statistically in ALPINE. In SEQUOIA, interestingly, we do see a same rate of hypertension between Zanubrutinib and chemoimmunotherapy, BR, which kind of tells you that the hypertension rate is close to the background risk. And same thing with atrial fibrillation, which is statistically not significant between Zanubrutinib and BR, although it was an unplanned statistical analysis, so we should remember that.
Thanks.
Mazyar, thank you for going over that. And you mentioned AFib initially with Ibrutinib, then acalabrutinib, and now Zanubrutinib. We are seeing this hint of better cardiac toxicity. So we do think that Zanubrutinib perhaps is better tolerated, especially with these cardiac side effects. So in your clinic, now we have these 3 options: Ibrutinib, acalabrutinib, Zanubrutinib. Is it safe to say that Zanubrutinib is your preferred choice, or what should be your preferred choice?
This is a great question. I mean, this is, of course, a very commonly asked question. I think what I can tell you is that we have 2 clinical trials that showed us that Ibrutinib is inferior to both acalabrutinib and Zanubrutinib. So that drug is easy to probably exclude from our options. And now the question of acala versus Zanu is difficult to answer. There's no head-to-head trials. These 2 studies are done in different times, different eras, on different patient population. ELEVATE-RR focused on 11q del17p patients. Patients had 1 prior line of therapy more than the patient population in ALPINE. ALPINE was an all-comer. But at the end of the day, the hazard ratio in ELEVATE was 1, and we just saw it with ALPINE. With the same kind of follow-up, you continue to see that efficacy. I mean, this is something that I do discuss with my patients, and as a practicing oncologist, you probably agree with me that patients care a lot about efficacy. I mean, they want their cancer to be treated and to be gone as long as possible. So that has been my experience, that I explained the 2 options, and have a very honest discussion, and most patients like the idea of having a better efficacy, and also both drugs have shown safety profile that's better than Ibrutinib. Now, every once in a while, if you have a patient with a very difficult to control high blood pressure on like 4 medications still uncontrolled, do I go with a CALA? Of course. But how common that scenario is in practice, most of the time these patients, it's not difficult to control their blood pressure. So in principle, I think I personally find these results very important in terms of the clinical efficacy, which is supported by the pharmacology of these drugs. If you look at the IC50 and the drug level that remains above the IC50 throughout the day, regardless of the dosing, that Zanubrutinib can be given twice a day or once a day, and no matter how you do it, the drug levels remain higher than IC50, and that talks about the exposure time and BTK occupancy. And even like one step back and looking at the two drugs, or Zanubrutinib specifically, we're now seeing that an approval just came for follicular lymphoma. You have in Waldronstrom, you have patients with wild type MYD88 that usually don't respond to Ibrutinib or other BTKIs, and you do see 30% response in Zanubrutinib. The CR rates that I saw. So I personally, in my experience and looking at the literature, I do believe that Zanubrutinib has a better efficacy, but I repeat that in the absence of a head-to-head trial, that would be a personal decision. And there are colleagues who may have a different opinion, and they're both great drugs. At the end of the day, we have a good problem here. So we won't go wrong with either of the two options.
No, absolutely. At least in my practice, same thing. We were all using Ibrutinib that got replaced by Calibrutinib, and now we're seeing more and more Zanubrutinib being used. Okay, so now switching gears to focus on Hodgkin's lymphoma. SWOG-S1826 was one of the plenary discussions at ASCO that we had a chance to cover with Dr. Jonathan Friedberg. Here, we're looking at an update, particularly in a patient population above 60. Mazyar, your thoughts here?
Well, a very important study, right? So, more than 900 patients were randomized in US, Canada. I mean, this was an amazing study in terms of the pace of design, enrollment, and report. And, my friend, Dr. Herrera, did a great job, and with Dr. Friedberg to really get this study going. And we had the results, as you mentioned, reported at ASCO and Lugano in 2023, clearly showing with the current follow-up superior efficacy of Nivolumab-AVD compared to brentuximab vedotin-AVD. And, with the same cutoff in this presentation, Dr. Rutherford looked at patients, elderly population, like age more than 60. As we know, these are patients who are historically known to have an inferior efficacy or outcome with classic Hodgkin lymphoma. So really the focus of this presentation was to look at that patient population and look at both efficacy and also some of the side effects, both side effects of interest that we have with immune checkpoint inhibitors like hypothyroidism and autoimmune conditions, and also neuropathy from brentuximab vedotin. And what we saw was a very clear advantage again in patients older than 60 with Nivolumab-AVD compared to Bv-AVD. And interestingly, I mean, remember that in the Bv-AVD arm, growth factor support was mandatory, but not mandatory in the Nivo-AVD. So the rate of neutropenia was slightly higher with Nivo-AVD, but did not translate to a higher rate of infection because those patients could be treated. But other than that, there was all the AEs were in favor of the Nivo-AVD. So this combination is not yet approved, but every once in a while we're able to get the drug for some patients. We try, and a great option I think for elderly population specifically. This was a very important report that really I think it's really practice informing. Hopefully when and if this combination gets approval, I think it will be widely used in all patients, specifically this patient subgroup.
Right, these results are very promising, and Nivo-AVD was again so well tolerated. As you talk about the growth factor not being utilized here as well. I know we are waiting for this regimen to be approved, but it is hard not to push for this already in our clinic, especially for this elderly patient population, given the incredible results that we see here.
Yeah, just this morning I got a call from a colleague in community having the same conversation. So we try. We try.
Indeed. We're at the mercy of insurance companies. So
yeah.
Okay, now moving along to our another aggressive lymphoma type, diffuse large B-cell lymphoma. POLARIX has provided us with another treatment option, which is polatuzumab for our diffuse large B-cell lymphoma patients. Here we see an update looking at different subtypes of DLBCL. Mazyar, your thoughts here about the study?
Yeah, I mean, I think this was a very interesting and important analysis from the POLARIX data. And, after a long time, we now have a regimen that's approved because it has been superior to R-CHOP in terms of progression-free survival, and it's available and approved for patients for IPI more than one. Many believe that it should be used for all patients, but that's the label. And then recently we had discussions based on the data, like a subgroup analysis, that the benefit was mainly seen in the ABC subtype and not in all comers. And we had some interesting communications from colleagues that was published recently in New England Journal of Medicine, and basically highlighting the importance of kind of maybe using it more for ABC subtype group. So this study tried to go beyond the cell of origin and look at some molecular subtypes that may also benefit from polar-CHOP, regardless of this cell of origin status. And they looked at subgroups like EZH2 mutation or BCL2 translocation, the MYD88 CD79B mutation, or called MCD, and they also looked at kind of what they call dark zone gene expression signature. So really the take-home point is the following. I think if you go by, and let's remember, on this study, the way they defined cell of origin is not the hand criteria that we use by immunohistochemistry in clinic. So we will be misclassifying some patients as between the ABC and non-ABC, or we may be misclassifying patients as not being ABC. And those are patients who could have benefited from polar-CHOP. So got to be careful about that, like lack of 100% correlation between the methodology that we use in practice versus what kind of the study used. And so that's one thing. The second thing, this study tells us that there are genetic subgroups that also benefit from polar-CHOP that may not necessarily fit under that ABC group. So my take-home point in practice is, the subgroup analysis is important, and you have a combination of chemoimmunotherapy that is more effective definitely in some subgroups, and also in the entire population of the clinical trial which reached the primary endpoint. And if we had a way of looking at all the relevant mutations and variations and cell of origin, and absolutely, if I knew 100% for sure that this patient will not benefit from polar-CHOP and on top of R-CHOP, then of course, I would have said, you go with a treatment that's less expensive, because that's really the only difference. I mean, the study is a double placebo-blinded study that did not show an increased toxicity with the polar-CHOP. So I can't make a case that, it's a more toxic regimen, I don't want to use it. It's more effective in all comers, definitely in the subgroup, and toxicity profile is not worse. So the only reason not to use it is like the extra cost that it brings to the healthcare system, and probably not even the patient. So if I had a way to exactly know who will benefit or not, then yes, I would have used R-CHOP in some subgroup. But we're not there yet. If you go by cell of origin, by immunohistochemistry, we will misclassify patients even for CO, and also we will, in practice, we don't check for these mutations, right? So there will be patients who have one of these mutations or alterations and could have benefited from polar-CHOP, and if we just go by cell of origin in the clinic, we will be probably undertreating some patients, in my opinion. So my take-home point is that, to me, standard of care is polar-CHOP in patients, at least by label more than IPI1. And, maybe there will be a day that we have all this signature next to us and know exactly who will benefit or not. But I think I would like to avoid undertreating some patients with the way the practice is today.
Mazyar, I think I'll add a few things. You've been talking about just how tough at times it can get to decipher these subtypes. This challenge, if anything, is bigger in rural or community settings where most of our patients are getting treated. That's where Rohit and I are practicing. So again, if in academia you're struggling with it, we're not checking gene sequencing. We don't have heme path. So I think it's important that sometimes these blanket approvals can help, and as oncologists, hematologists, we are always leaning to over-treat till we have a little more information and pick the right subset. But for now, I think it's fair to say that we should consider this for all intermediate high-risk patients.
I agree.
Well, thank you so much, Mazyar. We've covered quite a bit here. Thank you so much for taking the time to go over these practice-changing studies with us today. For our listeners, let us get over a quick recap. With Dr. Mazyar Shadman from Fred Hutch Cancer Center, we have covered 4 important studies from ASH 2023 in leukemia and lymphoma space. We started off with Zanubrutinib being a preferred BTK inhibitor for CLL or SLL, given its efficacy and better side effect profile.
Then we've also covered SWOG-S1826, which continues to show significant benefit with Nivolumab and AVD in our elderly patient population with advanced stage Hodgkin's lymphoma. We eagerly await FDA approval here.
At last, we also covered Polatuzumab being our new preferred option for diffuse large B-cell lymphoma, particularly for activated B-cell subtype disease. Thank you for joining us. Make sure to check out our recent highlights on myeloma from ASH 2023 and also San Antonio Breast Cancer Symposium. We are the Oncology Brothers.